Hello and welcome to Field Fisher's webinar. It's 4:45. We're just going to give people a moment longer to join us, so we'll be starting in about a minute or so. So welcome everybody to Field Fisher's webinar on eHealth, mHealth and 3 months of revolution. My name's Sarah Elson and we're delighted to have a very diverse audience, some of whom I can see are just beginning to log on now, joining us from across Europe and North America. As now is the norm in these webinars, you've been placed on mute, but you should find a question button in the sidebar, and please do use that to send us any questions you have, and time permitting, we will endeavour to answer your questions either during the webinar or after the webinar today, which we will keep to the 1 hour session finishing at 5:45 British Summer Time. As I say, my name is Sarah Elson. I co-head the firm's regulatory team, and my specialism is in health and life sciences. And I also chair the firm's health tech group, whose recent experience over the past few weeks and months led us to propose this event. I'll be followed in the presentation today by Clina McDonough, who's also a regulatory specialist, and she'll be speaking about apps and medical devices. And then we have a double act. I'd like to extend our particular thanks to Jacobin Zorin, the Chief Privacy Officer at Cepheid. Cepheid and Jacobin have been on their own accelerated journey, getting a COVID-19 test approved and rapidly into production in recent weeks. And Jacobin will speak with Nuria Pasta, one of Field Fisher's experts in data privacy. But first, I wanted to reflect on the revolution that has happened in online healthcare since the beginning of March. But before I do that, just a few definitions. What perhaps do we mean by digital healthcare? There's a range of technologies that we refer to when we speak about digital healthcare, and many of you on the call will work across one or more of these areas. They include eHealth and all the information systems and clinical data, electronic health records, but also the sensors, the med tech and the robotics involved these days in healthcare delivery. And we're also, and I particularly focus on this, referring to online services that provide support both to healthcare professionals and directly to their patients. We also have the terms eHealth and mHealth. In the next slide. eHealth, looking at the definitions often used perhaps in European directives or associated guidance, includes information that's stored electronically. So often it's the electronic health record, but also the software and the health information networks that go behind the communication of prescriptions and telemedicine. And by mHealth, we mean more the healthcare services supported by mobile devices. You'll be hearing more from Clina about apps, but also some of the tools that we see for remote monitoring, public health education, and training for healthcare professionals. So turning then to the online revolution in healthcare, I just wanted to go back in time, all the way back to 2015. Where the UK's regulator, known as the Care Quality Commission or CQC, was just beginning to scope out the online provision of online care for primary medicine. And it undertook a survey, and 319 practices that responded to that survey, none of them offered at that time online video consultations, and only 18 of them offered consultation by email. What emerged in England was the embryonic provision of online primary health services by private providers. And a number of those newly registered providers were inspected in 2016. The Care Quality Commission didn't like what it saw. It had various concerns about the quality of that care, and that led to the cancellation of one provider's registration. In 2017, by that point, 40 new providers had registered with the Care Quality Commission. Another set of inspections were undertaken, and the picture again was not good in the regulator's eyes. 35 of those provisions were inspected, and 30 of them were not regarded as safe. The things that bothered the regulator in terms of safety was the perhaps lack of monitoring of long-term conditions, a lack of clinical oversight of those providing the advice to patients, concerns about ID verification, information sharing with others who would be involved in the care pathway for the patient, and safeguarding issues. 35, all of the inspected services were not considered effective, and in particular there were concerns about the prescribing not being evidence-based. And 23 of the provisions were not considered initially to be well led, not least because of those other matters around safe and effective, but also a lack of quality assurance and quality management. By 2019, the problems had slightly moved on. And in September of this year, the regulator's main concern was that actually people were configuring services to deliberately evade their regulation. In the next slide, we'll see that their 2019 concerns again overlapped with what they'd found in 2017. They were very concerned that patient verification should be more strongly tested, and we're still awaiting the CQC's particular requirements for a verification and authentication standard. There is the development of one for our National Health Service, the NHS. They raised new concerns around mental capacity and the idea of consent, with particular concerns that two-way tailored communication wasn't always possible with certain types of online healthcare provision. Again, they were concerned about communication between different healthcare providers, particularly where the private sector might be providing medicine or treatment advice, and whether or not that information was being fed back to any National Health Service, family practitioner or GP. And again, safeguarding was raised. So what's happened? In the last few weeks, really, we've seen a revolution. In March 2020, as the UK went into lockdown, registrations for the NHS app, which enables people to communicate with their GP and order repeat prescriptions, massively increased by 111%, and requests for online repeat prescriptions went up by 97%. People got used to viewing patient records online, and those 319 GP practices who back in 2015 hadn't done video consultations had to learn very quickly. Our NHS Digital undertook a very intense 48-hour tender to select 11 suppliers to the NHS to provide video consultations, text messaging and automating triage. And so we've seen 11 suppliers step into that particular market, and clearly their journey has been especially accelerated. By the 6th of April, NHS had issued guidance to general practitioners, advising them, of course, in the current situation that remote consultation should be used when possible, and consideration should be given to video consultations. And by the 12th of April, reports showed that that GPs were now only seeing 7 in 100 patients face-to-face. We saw that revolution in primary care then spread into the secondary care and hospital outpatient environment, which initially I think had focused on being COVID ready, but then turned out turns its attention to outpatient consultations. And our NHS services use a platform called Attend Anywhere, who reported on the 11th of May that they'd now undertaken 79,000 outpatient video consultations, with a run rate at around that time of over 6,000 a day. And we also saw wider guidance coming from bodies like the General Medical Council, which regulates doctors, recognising that alongside their existing advice on remote consultations and online prescribing, doctors would have to get used to their delivery models being by other means. Over in the US, a similar story emerged. Medicare reported that almost 1.3 million members had received telehealth services in the week ending the 18th of April, compared with just 11,000 in the week ending the 7th of March, an increase of more than 11,000%. And to support that to happen, the Trump administration relaxed the reimbursement arrangements. Previously, virtual care was only reimbursed in certain narrow circumstances, but a widening of that made it available to a huge number of members. There are, of course, beneficiaries, again, to that opportunity. Very recently, we've seen American Well, one of the online doctor providers, raise $194 million in recent weeks, reporting, as they did, that in some geographies, their site visits had increased maybe 3,000 or 4,000%. And Cigna, another online provider, reported having over 14 million people enrolled in its Talkspace network of online therapists. Teledoc, another online service widespread in the US, has seen its share price rise from $83 at the end of 2019 to $169 at the end of last week. So, reflecting on where we are, I think I in no way want to belittle the concerns that our CQC regulator found, and of course, some of those will persist. But I think what we've been able to show is that telehealth can be done, and it can be done safely and at scale. A lot of the anxiety about whether it was doable, and a lot of perhaps healthcare professionals' anxiety has been overcome, and patients also too have often had a positive experience. It won't have been perfect, and I'm sure as we emerge from lockdown and can do some reflections on the healthcare provision online, we'll see what has worked and what hasn't worked. Who were these 7 in 100 patients that needed a face-to-face appointment? And were things missed through online consultations that a face-to-face consultation would have improved? However, and I'll count myself amongst these, there'll be many people who've now experienced an online consultation and found it incredibly convenient and efficient, who will now really want their online healthcare provider to offer that option. I think it does offer great new opportunities for those of you in this sector or thinking about it. And I think we will have to deal with the regulator's anxiety about cross-boundary, cross-geography provision. I don't think that providers were necessarily seeking to evade regulation by offering telehealth, perhaps from outside England to English patients. But we will need to think about how reassurance can be given for patient safety if we move forward with pan-geography provision and service. And there may be, I think, permanent changes to the payer model. Certainly, the Trump administration will have to consider whether that temporary changes to payment will be permanently put in place. And I anticipate that our NHS in England and other commissioners across Europe will increasingly include an element of online provision in future tenders. So I think there will be adjustments and lessons learned, but if you're looking at the provision of online healthcare, now I think is a great opportunity to reflect on the lessons learned and think about building out the provision in the months to come. Now, if it's something like apps and medical devices, you'll be interested to hear what Clina has to say.
Thank you, Sarah. Hi all, I work as a life sciences regulatory lawyer here at Phil Fisher, and one of the very busy areas of life sciences that I advise on nearly on a daily basis is with regards to compliance with European medical device regulations. So to this end, I will deliver a brief overview of the regulatory obligations that a manufacturer or a distributor or an economic operator must adhere to in order to ensure the lawful sale of a medical device software, such as, for example, an app on the European market. So where an app or a software is a medical device or an accessory to a medical device, it will need to comply with the regulatory framework if it is to be sold or distributed lawfully in Europe. In the UK, failing to comply with regulations can be seen as a civil and/or criminal offence. So the key question for most developers is this software a medical device? And if we look at the definition of a medical device, it's divided into two parts. The first question is, does the device have a medical purpose? In that, does it provide a diagnosis, prevention, monitoring, prediction, prognosis, treatment, or alleviation of disease? And if it doesn't have a medical purpose, it's very unlikely to be a medical device. So you most probably will not have to comply with the Medical Device Directive or the forthcoming medical device regulations, but you will need to comply with other regulations such as GDPR. The second part to the definition of a medical device is there an intended action in or on the body? And it is not to be achieved by pharmacological, immunological, or metabolic means. And if it is achieved by those means, anything which operates in this manner is likely to be classified as a medicine and not a medical device, and therefore subject to regulatory applications under medicine legislation. But if it assists, if the device is assisted by such a function, for example, does the software provide information used to make diagnostic or therapeutic decisions? We see this in AI software to diagnose cancer or blood sugar monitoring for diabetics, then it could be a medical device. But essentially, software is specifically included as a medical device under the present directives, the MDD, and the forthcoming medical device regulations. So speaking of the MDR was enacted, as most of you are well aware, in 2017, and it becomes mandatory from May 2021. There has been a 1-year delay in application due to COVID-19. So under the MDR, it is stated the natural or legal person placing the medical device on the market bears responsibility for compliance, even if design, manufacturing, or labeling is carried out by a third party. So in order to complement the new MDR, the European Commission, or rather the Medical Device Coordination Group, in 2020 published harmonised standards to complement the application of the legislation. So the Medical Device Coordination Group is composed of representatives from all EU member states and is chaired by a representative from the Commission. So as most of you may or may not be aware, the older MedDev 2.1/6 guidelines complemented the Medical Device Directive. We're now looking at the MDCG guidelines, which I know as of today have been updated to complement the application of the medical device regulations. So essentially what these are is standards that provide solutions and guidance for compliance with the legislation, so that manufacturers, economic operators, or conformity assessment bodies can use these harmonized standards to demonstrate that products comply with the MDR. Next slide, please. So in terms of qualification of a medical device, as we've mentioned there in the previous slide, the manufacturer must intend a medical purpose. Now, to bear in mind, this purpose is demonstrated not just by how the device works, but also the data supplied by the manufacturer on the labeling, the instructions for use, promotional material. Therefore, how a manufacturer or app developer advertises or describes the product is very important. If the app carries out an analytical function or interpretation of gathered patient data to carry out therapeutic function or trigger an alert, it is likely to be a medical device. So by way of example, a wearable which detects and records body temperature is unlikely to be a medical device on its own. Conversely, a smart thermometer, which most of us may or may not be using, I know I have one, it comes in very handy, but essentially it detects and records body temperature, but then it can alert the user to indicate whether or not there is a medical condition. This is seen as a medical device. If data is stored archived, or search, then it will not qualify as a medical device. An example there is an app which integrates with a surgery's booking system, your doctor's surgery's booking system, to speed up booking of an appointment would not be a device. And just to bear in mind that the risk of malfunction is irrelevant to classification, and further assessment will be undertaken in order to award a CE mark and classify the class of software that the medical device falls into, such as carrying out clinical investigations, and this demonstrates the device is in compliance with the regulations, quality assurance checks, and compliance with harmonized standards. Next slide, please. So under the present medical device directives, the classification of a device reflects the risk of harm that a medical device possesses. So for example, class 1 possesses the lowest risk, while class 3 has the highest. So the legal obligation to which a manufacturer must adhere depends on a device's classification. So presently, under the MDD, most software falls into a class 1 risk classification. So that basically means that the manufacturer can self or partial declare a certification. However, class 2A is moving up in terms of the device risk, and it is defined under the present MDD as software which provides direct diagnosis or monitoring of vital physiological processes. So for example, if you're using a blood sugar monitor for diabetics, these measure vital parameters where variations could result in immediate danger to the patient. And further up the risk classification chain, we have class 2B, and this risk is specifically intended for monitoring vital physiological parameters and variations, which may result in immediate danger to the patient. So another example to reflect this class would be radiotherapy planning software. And these decisions could result in a serious deterioration of a person's state of health or indeed surgical intervention. So just to bear in mind, both class 2A and class 2B require full CE certification via a notified body. And in order to achieve that, you have to submit, obviously, your dossier, but in addition to that, your clinical evaluations, your compliance with ISO 13485 at the very minimum, in order to be awarded a CE mark. So as we move into compliance with the new medical device regulations, we will see that one of the biggest changes under the MDR is its focus on software and digital applications. And interesting, standalone software will now be classified based on intended purpose and risk assessment, and not just based on purpose alone, which is what the present MDD is ensuing. So the Rule 11 of the MDR gives us an understanding of the definition of risk and how risk is classified. And overall, we will see an upgrade of medical device software in terms of risk and a change to the risk definition compared to the MDD. So most medical device softwares will now be classified as a class 2 or higher risk. So in terms of definition, a class 2A software has an intended purpose to provide information used to take decisions with diagnosis or therapeutic purposes. So for instance, an application collecting uses data for the purpose of general well-being, like weight loss, is seen as, quote, a well-being app. However, the same app collecting the same data for treatment of an eating disorder or diabetes will be under the medical device regulations, a class 2A or higher device. Class 2B will be defined as where such decisions by the software may lead to a serious deterioration of a person's state of health or surgical intervention. And we will also see a class 3 risk for medical device software. So this is where the device could lead to death or irreversible deteriorations of a patient's health. So as I said, under the MDR, there's a new class of high-risk software. And importantly, this includes standalone software. It needn't be connected to any hardware. What matters is if the software provides information to make decisions. So hence, on an app calculating the correct dosage for medicines, this will now be a class 3 device. And this is because if it makes a mistake, it could cause death from a medication overdose. Next slide, please. So my final slide will just give an overview of a new regulatory era for tech health. And the entry of tech players into the health market will mean a change in paradigm. It would not be an overstatement to say that the application of next generation technology and the entry of tech into the health market will mean a change of paradigm, which would be similar to that of which we've all seen since the introduction of penicillin a century ago. Now, the European Commission has been very vocal in its support to revolutionise eHealth, mHealth amongst most member states. So, for example, in April of this year, the European eHealth Network published the EU Toolbox and Guidance for the use of technology and data to address the COVID-19 crisis, otherwise known as the recommendation. So essentially, the toolbox was accompanied by guidance from the Commission with regards to data protection and privacy aspects of using app tracing technology during COVID-19. But it only applied to voluntary apps, i.e. those that have been downloaded and installed on a voluntary basis by individuals. The European Commission has also supported eHealth through funding from Horizon 2020, and this is important because it financially supports research and innovation projects in the field of eHealth and telemedicine, specifically in areas such as diabetes, mental illness, and cardiovascular disease. We've also seen an increased use of apps for real-time clinical collaborations, and this effectively will allow users to report data about real-world nature of diseases to not just help themselves, but to help other researchers, pharmaceutical companies who are going through the R&D process, and indeed national and European international regulatory bodies to help them develop more effective products, services, and care. And finally, the European Commission initiative for linking genomic databases has the aim of sharing genomic data to improve the understanding and prevention of diseases amongst member states and to allow for a more personalised treatment, such as targeted drug prescriptions, in particular for rare diseases, cancer and cardiovascular disease. So that is it from me. If I can hand you back to Sarah, and I'm happy to answer questions, perhaps now or after the session.
I think we'll hear from Nuria and Jacobin. Thank you.
Super, thank you.
Thank you very much, Clina. Hello, everyone. So Jacobin and I are going to look at the legal challenges facing those developing or rolling out technologies and new data processing activities in the context of the COVID-19 pandemic. Jacobin will provide us with the US perspective, and I will focus on the EU perspective. A few weeks ago, in a statement, the ICO, the UK data protection regulator, that is, reminded us that a few decades ago, data protection laws emerged out of the concern that people would not embrace the advances of new technology because of their fear for their privacy rights. Fast forward to March 2020, and data protection law is here performing this role. In this slide, we provide a few examples of some of how technologies are being used in the COVID-19 crisis. Personally, I have advised a number of clients in the use of symptom control measures in a number of ways. For example, temperature control stations as an access control measure for accessing the work premises. Also, the development of symptom control, symptom reporting apps, and the use of heat cameras in order to spot individuals who have a temperature. I've also recently advised clients using certain apps for the remote delivery of patient appointments, which we have mentioned before during this seminar. So now Jacobin will share with us her experience at Cepheid in the US.
Thank you, Nuria. As mentioned by Sarah, my company is a medical device manufacturer. Our products are used to diagnose diseases like flu, tuberculosis, and now COVID-19 under an emergency use authorization. In addition, we offer our C360 web portal that displays trends across a hospital or lab's various sites so they can track where resources may be needed most. Obviously, this is an important feature when the healthcare sector is so overstretched right now. And internally at Cepheid, as Nuria mentioned, we are performing things like temperature checks. We are also working from home, a lot of us. And we're also considering how to test all of our employees when we come back to the office. One of the things that we're asked the most by our own employees is, hey, we make a great test, when can we have it used on ourselves? So the executives are working on that. But making sure our teams are actually healthy, the ones that have to be on site, because we do manufacture and we do have various sites that manufacture. We need to make sure that those employees stay as healthy as possible, so the rest of us have stayed away. Besides consideration of my own company, we're also being asked how other companies can test their employees as more and more of them go back to the office. This will be an interesting struggle, as most companies will need to bring in third parties to perform that testing. And as well as the complexity of testing and reporting results, the need to maintain employee privacy is paramount. So speaking of privacy, Nuria is going to take us on a journey through the world of data protection laws and how, at least the EU side, and how these affect the current initiatives of fighting the pandemic.
Thank you, Jacobin. So any organization setting out new data processing activities or developing new technologies has to ask itself a number of questions, some of which we provide in this slide. I will not read out the questions, but in the next few minutes, we will unpick some of these issues and explain what they mean in practice. So we can go to the next slide, please. Thank you. So the first question was, will I process personal data? To state the obvious, data protection law does not apply if you do not process personal data. Under European data protection law, personal data is a very broad concept. Any information relating to an identified or identifiable individual will be personal data. So I provide a few examples in the slide. You should avoid processing personal data if you do not need to. If you can achieve the same result by using pseudonymized or an anonymized data set, you should. Healthcare data falls under a subcategory of personal data known as special category data, which requires additional attention. Now Jacobin will explain the concept of personal data under US law.
Yeah, in the US, we have a law called the Health Insurance Portability and Accountability Act, or HIPAA for short. And the definition is similar to personal data under GDPR, but only as it relates to health data. So protected health information is the way it's defined instead of personal data. PHI is our individually identifiable information that relates to an individual's past, present, or future physical or mental health, to the provision of healthcare to an individual, or to the past, present, or future payment for the provision of healthcare to the individual, and either identifies an individual or for which there's a reasonable basis to believe it can be used to identify an individual. Next slide, please.
Thank you, Jacobin. So let's look at the applicable laws in the EU. So once you have established that you process personal data, you'll have to consider what privacy laws apply to such processing activities. In the EU, the General Data Protection Regulation, or GDPR, applies to processing activities carried out within the EU, but also outside of the EU by organizations who target or monitor individuals in the EU. Whilst the GDPR is the foundation of the data protection law regimes of all EU member states, EU member states also have their own local data protection laws which supplement the GDPR, and these are also likely to apply when you process health data. In the UK, Schedule 1 of the Data Protection Act 2018 sets out additional conditions in order to process health data. In addition to the GDPR, certain processing activities may also be subject to the e-privacy rules. In the EU, this comes in the form of the e-privacy directive and local laws in each member state. Processing activities that will be covered include the installation of an app in a mobile device, access to the mobile's camera, for example, and the use of cookies or other tracking technologies. Other sectorial laws may also apply, for example, health record regulations or clinical trial regulations. Please, can we go to the next slide? Thank you. So, the next question organizations need to ask themselves is whether they hold the personal data as a controller or as a processor. In a nutshell, a controller will decide how the personal data is processed and for what purpose. The processor will process the personal data on behalf and for the benefit of the controller. In practice, the concept of controller and processor often blur. It is very common that sophisticated processors also act as a controller when providing their services. For instance, if they wish to use the personal data they hold on behalf of the controllers for the purposes of developing and further improving their services. This is fine as long as it's clearly set out in the contract. So now Jacobin will take us through the applicable laws in the US. Next slide, please.
Thank you. Switching back to the US, in many ways, the treatment of health data is similar to that Nuria just mentioned in the EU. We have a top-level structure consisting of HIPAA and HITECH, which is the Health Information Technology for Economic and Clinical Health Act. The Department of Health and Human Services Office for Civil Rights enforces, among other things, HIPAA's privacy, security, and breach notification rules and the Patient Safety Act and rule, which together protect health information privacy. HITECH addresses the privacy and security concerns associated with the electronic transmission of health information, in part through several provisions that strengthen the civil and criminal enforcement of the HIPAA rules. Like the EU, many states also have their own version of privacy laws, and some are very specific in terms of health information. In the past couple of years, the US has seen almost 24 states propose new laws relating to various data protection, not just around healthcare. There are also many sectoral laws, both at the federal and state level, that cover non-health data like credit cards, student data, and telecommunications. Next slide, please. And similar again to the EU, we don't have the concept in the US of controller versus processor. However, under HIPAA, there's a similar idea, namely the covered entity versus the business associate. These are two very much like the EU standard in that the covered entity determines how PHI is processed and for what purpose, whereas the business associate processes that PHI on behalf and for the benefit of the covered entity. Next slide, please.
Thank you, Jacobin. So we'll now move on to look at the principles of data protection law. So the data protection principles are the pillars of data protection law. We will not have time to go through every single data protection principle today. So they all apply to the processing of healthcare data, but I will highlight three which are particularly relevant in the COVID-19 context. I will start with the purpose limitation principle. Under the purpose limitation principle, personal data must be collected for a specified, explicit, and legitimate purpose, and not further processed in a manner that is incompatible with those purposes. In practice, this means that you need to properly spell out the purposes for which you will process the personal data and stay within those parameters. In these times of uncertainty, it would be quite easy to fall a victim of scope creep and lose sight of the initial purpose for which data was obtained. That's why I thought it was important to highlight this here in this webinar. So next I will focus on the data minimization principle. Under the data minimization principle, personal data must be adequate, relevant, and limited to what is necessary in relation to the purposes for which they are processed. Avoid collecting excessive data with a mindset that it might come handy in the future. This is particularly relevant in the COVID-19 context. For example, when carrying out temperature checks, controllers are likely to need the actual temperature reading, but only if the temperature is above a certain threshold that they have set up. Last but not least, I will address the accountability principle. The accountability principle sets out that it is the controller that must ensure compliance with the data protection principles and be able to demonstrate compliance. In order to demonstrate compliance with the principles, in many cases, controllers will need to develop records and policies. In a COVID-19 context, accountability is more important than ever because it is a fast-changing environment. Documenting what has been done and the underlying legal assessment is essential. It's also crucial to keep such assessment under review because what's a compliant measure today may not be a compliant measure in the near future. So now Jacobin will take us through the HIPAA principles. Next slide, please.
Thank you. So the HIPAA rules or the HIPAA principles are basically broken down into 4 main areas. The privacy rule covers how and when PHI, that protected health information, may be used and disclosed. It sets out the requirements for both the covered entity and the business associate and describes the necessary policies and procedures that have to be adopted. The security rule is specific to ePHI, or electronic protected health information, and sets forth specific policies, procedures, and technical safeguards that must be in place to protect ePHI. These requirements include administrative, physical, and technical controls. Next is the breach notification rule, which sets out the timing and notifications required if and when a breach occurs on data. And finally, the enforcement rule explains the penalties that may be imposed if any of the other 3 rules are not followed. Next slide, please.
Thank you, Jacobin. So we will now look at a few practical compliance steps that are particularly relevant when rolling out new processing activities or developing new technologies in the COVID-19 context. Organizations will have to provide clear privacy notices. Controllers are required to provide certain information to individuals about the processing activities they are planning to carry out at the time when the data is obtained. This information has to be clear, transparent, intelligible, and it has to be tailored to the audience. In a healthcare context, there will be an overlap in the regulations regarding patient information notices, so organizations will need to ensure they comply with both. One of the elements that controllers must include in the privacy notices is what are the lawful grounds for processing the controller relies on. There are 6 available grounds for processing in Article 6 of the GDPR. These are consent, legitimate interest, and performance of a contract, legal obligation, vital interest, and public interest. When processing healthcare data, in addition to Article 6, legal grounds for processing, you will have to meet one of the conditions of Article 9 in the GDPR. There are quite a few, so I won't list them. Furthermore, many EU member states' data protection laws set out additional conditions related to healthcare data that you will have to comply with, as I explained earlier. In the COVID-19 crisis, EU data protection regulators have issued guidance about what may be the applicable legal grounds for processing personal data, for example, when processing personal data for symptom monitoring. Consent is unlikely to be a suitable legal grounds for processing in this context because it will not be freely given, which is one of the requirements under the GDPR. This is particularly tricky in a healthcare context where patient consent is required under healthcare regulations, so you will need to be careful so that individuals understand what they are consenting to. Regarding the processing activities for COVID-19 purposes, it is more likely that organizations may rely on the fact that they are required by law to carry out certain processing activities, for instance, to ensure a safe environment for patients or employees, or protecting public health. Data protection impacts assessments have to be done where controllers carry out high-risk processing activities, some of which are listed in the GDPR. Regulators have also published additional lists. Going back to the technologies that we mentioned in our first slide, they would also all require or will be very likely to require a DPIA. A DPIA requires organizations to document the processing activities and the steps it will take to comply with privacy laws and mitigate any risks to the privacy rights of individuals. This assessment will need to be kept under review. The requirement of putting in place privacy by design and by default measures may be challenging when setting out new processing activities in a rush, which is something controllers have had to do in the recent months. But what is privacy by design and by default? The GDPR codifies these principles for the first time. In practice, it means that the privacy principles cannot be an afterthought, that they must be embedded when designing for, preparing and carrying out processing activities. In practice, this may be achieved by pseudonymizing personal data as soon as possible and minimizing the data that you process. Next slide, please. Another really important compliance step is that you ensure you have all the relevant contracts in place with processors and controllers you engage with. The GDPR sets out a minimum set of terms that must be incorporated in controller to processor contracts. This will impose restrictions to the processor to what they can and cannot do. For instance, they will restrict the way in which they can engage subcontractors. In the health sectors, there are many examples of organizations that will act as processors. For example, any organizations who will develop and maintain technology for you. So for example, an app developer. If you are in the EU and will transfer data to organizations outside of the EU, you will have to ensure the data is safe. There are many ways in which you can overcome the GDPR restrictions to transferring data, and we cannot go through them all now. The most common approach, though, is that data exporters and importers enter into certain contractual terms that the European Commission has set up for these purposes. Properly handling data rights. Actually, can we stay in the previous slide? Thank you, Chloe. So I'm now moving on to the data rights requests. So properly handling data rights requests is also paramount. Individuals have a number of rights under the GDPR, including the right to request a copy of their records or for the records to be rectified or deleted. Be ready to honor such requests, have a process in place and train your staff to identify when such requests have been made. There are timescales too that need to be observed, and generally these have to be implemented within a month. Last but not least, keep personal data safe. This is a cornerstone of data protection law, and it becomes crucial in a COVID-19 context for a number of reasons. The working from home environment may mean that organizations decide to deploy additional measures in order to increase security, for example, additional layers of authentication. Organizations will have to take measures to train the workforce in order to increase awareness of security policies, acceptable use policies, and working from home policies. The ICO has published extensive guidance on this. In the COVID-19 crisis, unfortunately, there have been reports of an increased level of phishing attacks. Employees will have to be trained so that they don't fall for this and put the systems at risk. Furthermore, employees will have to be able to identify security incidents and know who to alert in the event of an incident. Organizations will have to have procedures in place to deal with security incidents and meet the relevant GDPR requirements, including notifying regulators and individuals where necessary. So now Jacobin will take us through the similarities between the HIPAA and the GDPR regime.
Thank you. Yes, here again, there are similarities between the two regimes. While HIPAA only covers health information, there are still several items that mirror what Nuria has just discussed. These items include the use and disclosure of data for purposes of treatment, payment, or business operations without an individual's express permission or consent. I think of it as lawful processing, like legitimate interest under GDPR. Identification of risks via an annual HIPAA risk assessment is required. That to me is like a DPIA review just done annually. Also, notices to individuals about what will happen with their data when they go to a doctor's office or to a hospital is important to make sure that that's complied with. And also a purpose limitation in GDPR is called the minimum necessary rule under HIPAA. So basically, again, as Nuria said, it's just collect what you need, not what you think you might want in the future to develop a new product or something. And finally, contracts. Similar again, HIPAA requires agreements between covered entities and business associates, detailing the processing of the protected health information that the business associate will do. And these are called, very obviously, business associate agreements. Next slide, please. Thank you. Before I describe a few of the relaxation measures that have been taken due to the pandemic, I'd like to add a comment about security. As Nuria mentioned here, in the medical device field, we're certainly seeing an uptick in the number of attacks on hospitals and lab equipment. Privacy by design is such an important component to fighting such attacks, as are simple things like keeping software patched on your PC. Though HIPAA does not call it that, it's similarly covered in the security rule. We should make sure that health providers purchase products that have privacy and security built in. So that's something that the manufacturing companies do try to work on. Turning to the recent changes, at least temporarily, some of the requirements under HIPAA, on March 15th, there was a limited waiver issued removing the following requirements: to obtain a patient's agreement to speak with family members or friends involved in the patient's care, honoring a request to opt out of a facility directory, distribution of privacy notices, a patient's right to request privacy restrictions on their data, and a patient's right to request confidential communications. Obviously, all of these are around sharing data without consent or without knowledge of the person. Second one was on April 2nd. The Health and Human Services announced it would exercise its enforcement discretion and not impose penalties for violations of certain provisions of the HIPAA privacy rule against healthcare providers or their business associates for good faith uses and disclosures of protected health information by business associates for public health and oversight activities during the pandemic. This gives business associates, which is a company like Cepheid, we are most of the time considered a business associate, gives us greater freedom to cooperate and exchange information with public health and oversight agencies, something that we are not normally allowed to do. Usually it is only the covered entity that's allowed to do this. So we have, obviously a lot of us in this field have been asked to share additional information that we normally would not with the public authorities around the world. On April 9th, the Health and Human Services announced that it would exercise its enforcement discretion and not impose penalties for violations of the HIPAA rules against covered entities or business associates in connection with the good faith participation in the operation of COVID testing sites. So this is to support certain covered healthcare providers, including some large pharmacy chains in the US and their business associates that may participate in the operation of a community-based testing site like mobile or drive-through or walk-up sites that only provide COVID-19 specimen collection or different testing services to the public. And lastly, there was a White House coronavirus task force communication at the end of March that requested a daily report by 5 p.m. Eastern from all hospitals, commercial and private labs via spreadsheet to FEMA, as well as a daily report to the Centers for Disease Control and Prevention's National Healthcare Safety Network, describing healthcare-associated infections to monitor illnesses, deaths, and impacts on hospitals. So that's been quite a challenge for, luckily not for Cepheid, but for obviously the covered entities that we support. And now Nuria will wrap up with some of the details of measures taken by several of the EU data protection authorities.
Thank you, Jacobin. So all regulators in Europe, all data protection regulators have made clear that the GDPR should not be an obstacle to fighting COVID-19. Regulators have also made clear that the GDPR remains in place and that the rules haven't changed or haven't disappeared. However, some regulators have acknowledged that their regular activity will slow down because they are dealing with COVID-19 specific matters. In my experience, the ICO has been the most transparent regulator in setting out how it will enforce in a COVID-19 environment. In a nutshell, we can expect the ICO to be empathetic and pragmatic and to focus its effort on the most serious challenges. We have seen that the ICO has paused its audits and some investigations, We have also seen that the ICO has delayed some fines that it was about to impose. Other regulators like the CNIL in France and the Garante in Italy have publicly acknowledged that they are taking a more focused approach and pausing some of their regulatory activities. Other regulators have instead made statements that they are more active than ever. However, they have been limited in their activities by COVID-19 legislation. So, for example, in Spain, the state of alarm that was declared a few months ago has limited the ability of the Spanish Data Protection Authority to issue decisions. This means that we cannot relax, especially when setting out new processing activities and new technologies, which will allow for the processing of health data, as these will be always high in the priority list of any EU data protection regulator. And this is all from me. Thank you.
Thank you, Nuria. So we just have a few minutes left, and again, I'd remind you, if you want to ask a question, given that you're muted by microphone, you're very welcome to post questions via the question tab on the software. We've obviously just heard from Jacobin and Nuria about some of the relaxation that there has been, both, I think, actual deviations from normal regulatory rules, and also, I suppose, a mindset and approach to enforcement, or perhaps not enforcing, or enforcing in a very focused way. And I think I was asked about whether we've seen similar changes in the regulation of online health providers and medical device approvals. As I say, I think for the CQC, who would register and monitor the behaviour of online providers, probably they're finding it quite hard to get visibility on behaviours. They would deal with any serious complaints or information passed to them, but their inspection programme is obviously on hold. So we'll perhaps wait to see. I expect they will do an annual review and report to us what they found. There hasn't been any official softening or changes to the legislation that they operate by, but I do think that regulators have some flexibility in enforcement. And I just wondered, Clina, whether you wanted to answer that question from the perspective of the medical device regulations or directives, whether there has been any official softening or expedition to the market for the circumstances we find ourselves in.
Sure. Well, certainly the MHRA at the very beginning of the COVID-19 crisis did issue, I suppose, a loosening of regulatory compliance per se with regards to PPE, which is personal protective equipment, and ventilatory equipment as well. Now, that being said, a lot of the PPE equipment just required a CE self-declared mark. So, for example, if a developer or a manufacturer wanted to put on the market a higher risk PPE product, it would still have to go through the MHRA and notify them in any event. But the trust would be there that the manufacturer would continue to comply with the requirements as laid out under the Medical Device Directive, and more importantly, the technical requirements. So to answer the question, there has been a loosening, once again, when it comes to PPE and ventilator equipment, but certainly in a very transparent manner. And the reason being is that if medical devices that require a notified body certification before it would be placed on the market, it simply wouldn't be possible given the climate that we are in.
Yeah, thank you. And a question probably best put to Nuria. One of our attendees asked whether you can talk at all about Germany's Digital Health Act. I don't know if that's something that's come across your horizons, or whether we might want one of our German colleagues to help with that after the webinar.
Yeah, probably that would be best. Thank you.
So that attendee will come back to you, introduce you to our German colleagues. Well, I'm mindful of the time. We're just approaching the 1 hour mark. I'm delighted that so many of you have joined us today for what I hope has been a reflection on the regulatory world, both the perspectives that Clina and I have and our two privacy specialists, and how they've been altered by the last few months. I think essentially perhaps the message to take away is that some of the essentials are still very much in place. They were put in place for good patient safety and privacy reasons, and they remain in place. But what we have seen is innovation and the desire to change the way we operate. And I hope what we'll also see is a flexibility by our regulators where people have done things in good faith in public health interests to support those companies who are trying to innovate safely and appropriately. It goes without saying that if there's anything we can help you with, if you're developing products or innovation or ideas and have questions in this area, we'll be delighted to help you. Our contact details are available, and we'll also be doing some follow-up on the webinar, both with the ability to share the slides and the recording of the session if anyone would like those for themselves or perhaps for a colleague who's been unable to attend. It remains for me just to thank you all for attending and hope that you all keep safe and well, and that one day we might see you in real life, a seminar together at Field Fisher's offices. Thank you very much indeed.